I see so many familiar names. Sorry, we cannot be in person, but for our safety. So thank you all and happy Thursday for joining us today for our follow-up event. We'll do this one a little bit different. So let's talk about action. Let's jump in. Next slide, please. Next slide. Okay, perfect. Thank you. Next slide. Thank you, Phil. All right, from our last event on June 19th, that was our first event, and hopefully with a start of that slide. Hopefully, as we start this new initiative in which we continue to meet and touch bases just quarterly on this important topic. So from our last event, we reviewed the 2019 data, and of course we saw the alarming disparities that existed between Blacks and whites who actively use drugs, but specifically when we look at the overdose death rate. Out of this meeting, we highlighted key issues. We discussed key areas that unfortunately have been lacking resources historically. We also discussed poor retention and treatment outcomes across the board in the state of Missouri that also included FQHCs as well. We also discussed the lack of culturally responsive and humble services. And of course, we cannot leave out the importance of the impact of racism and its effect with this idea with war on drugs. So of course, that's the root behind a lot of this. So thank you for gathering. We heard from you. Some of the key takeaway points was that we understand and recognize we need more representation from Black men, especially those who use drugs. We need this work to be community-centered as well. It's not only on one person, but the entire community. Our system needs to change. And then we also need more details about existing efforts and hold all of us more accountable for some of these changes. Next slide, please. So today, Dr. Winograd will share our 2020 data. We'll also hear from our 6 wonderful panelists on what they're thinking, doing, and how they want to respond to this crisis. And then lastly, we'll open up with a Q&A so we can continue to have this honest feedback, discussion, and dialogue so we can continue to move forward. I do want to remind everyone that this webinar is recorded, so you can please share this on your Facebook, social media pages, and then also definitely you can review it later. I will turn it over to Dr. Winograd so we can jump into the data, and thank you again for you all attending our second webinar event. Dr. Winograd?
Thank you, Dr. Turner, and please call me Rachel. Next slide, please. Last time we discussed the 2019 data for the St. Louis region, but as we know, 2020 is a very different year. So since that time, we've gotten regional and statewide data on the impact of COVID-19 directly and indirectly on the overdose crisis in our state and in our region. As we all feared, it has gotten a lot worse. The worst months by far were April and May of 2020. This is Missouri statewide data that you're seeing here on the screen. You'll notice that the months of April and May were in April's case, it was more than double, and in May's case, it was almost double the number of overdoses we had in those months compared to the year prior. So since the late spring, things have still been bad, but not quite as bad. Next slide. Here in our region, when we disaggregate the data by race and sex, we see a trend that has become too familiar in the last 3 years, such that the increases among Black people are larger than the increases in deaths among white people. So specifically across Black males and females, there was a 64% increase in overdose deaths in the first half of 2020 compared to the first half of 2019, compared to only a 40% increase among white people. Now, to be clear, this increase overall is horrific, and that the fact that overdose rates are increasing across the board is devastating, and we're seeing this nationally. But the topic of today's session is again to focus specifically on the disparity between Black deaths and white deaths, and on top of an already record-breaking year that was 2019 for deaths among Black people in St. Louis, the fact that they increased 64% is incredibly alarming and in need of swift action and attention. Next slide, please. So before we kick it off to our panel, we wanted to give a group update, something that we are excited about, though it is just one small piece of this very large and complicated puzzle. Since we last convened in June, many of us from that call put heads together and put in a proposal to the Missouri Foundation for Health, their opportunity fund focused on equity. And we are very grateful to have gotten funded with that proposal. The working title right now is Community Engagement to Reduce Overdose Among Black Men in North St. Louis. We might come up with something a little catchier down the line. The main partners include the T, Power 4 STL. You'll hear from Dr. Punch in a moment. They'll represent the on-the-ground hub and heart of this grant. Family Care Health Center and Dr. Kanika Turner, who you just heard from, the Community Health Worker Coalition, the Regional Health Commission, the Integrated Health Network, the Behavioral Health Network, and us at UMSL in the Missouri Institute of Mental Health, as well as the Psychological Sciences Department and the College of Nursing. The goals of this grant are really twofold. One, to identify priorities and key recommendations to advance the health and well-being of Black people who use drugs in North St. Louis, as well as to lay the groundwork for infrastructure in the form of developing a harm reduction coalition led by directly impacted people from these communities. This will be a mechanism of sustainability going forward so that this coalition can lead a lot of these efforts in the months and years to come. This grant starts on January 1st and will go for 3 years with a funding amount of a little bit over $3 million. The need for this came out of a broad recognition that though we have many promising initiatives in St. Louis that are offshoots of other grants, this warrants its own funding stream and dedicated attention. And the way that we will be doing this is really through deep partnerships with organizations and people already there, already on the ground doing this work or doing branches of related work, elevating the voices of people who are most impacted and identifying and building champions to take the torch going forward. And so it is without further ado that I will now, next slide, please, introduce our moderator for this event, and that is Lauren Green, who is the Harm Reduction Program Manager with us at UMSL-MIMH, and she's going to kick off with some housekeeping and then introduce our panelists. Thank you.
Thanks, Rachel. Next slide. So I'm going to start off with some housekeeping notes here. Please use our question and answer function to ask any questions that you have. We've already started submitting some that we received prior to the webinar. Those are in the Q&A already. If you feel more comfortable, you are able to submit your question anonymously. Please also upvote questions that you want answered. That's how I'm going to be choosing which questions to ask. So if there's a question that you would like asked, upvote that. Also, feel free to use the chat function to communicate with one another and add a comment to the group. In an effort to get through as many questions as possible, I'm going to ask the panelists to limit your responses to questions to just a few minutes. I will say we're going to keep track of the questions that don't get answered and try and send out answers to those following the webinar as well. And we'll share slides, recordings, and main takeaways following the webinar. Next slide. All right, I am excited to introduce our first two panelists, Dr. LJ Punch and Marcus Hunt from Power for STL and the T, to share more about their work. Take it away.
All right, can you hear us?
We can.
Mr. Hunt, microphone check.
Yeah, am I live?
There you go. Can we see our next slide? So the first question we were asked is to reflect on core reasons or root causes for the inequities and overdose in St. Louis. Marcus, do you want to go first and reflect on some of our points here?
You can go first.
Okay. Well, you know, we answered these questions together, and our collaboration has really been enlightening to me with Marcus and his team working at the T. But it seemed that a lack of access to resources and effective ways to deal with trauma, trauma itself being the true gateway experience that brings people into the unmitigated pain that drives the demand for drugs. Drugs work at treating pain, emotional suffering, and a world of other psychological, spiritual, and bodily trauma. We know that there are very few success stories that people can refer to of people being able to reverse the trend in their own lives once that trauma is treated by drugs, and that the lack of stories really has created a lack of hope, and that the environment, not just the physical environment, is what drives the lack of social support. That is really what would be a key to being able to undo that trauma. Are there any of these points in particular, Marcus? I know that first one really came out of your mouth.
So one of the main things that I'm seeing is, the main way that people access medical treatment for their addiction is through inpatient treatment. And that's something that high poverty individuals, especially Black males, don't generally have access to in the Metro St. Louis area. So, the main way, or the main thing that's available that would, stem this drug addiction or stem this tide is just cut off from these people. Same thing with the education that should come out of a medical facility. Same thing with the wraparound services that will be paired with, this kind of problem if we were actively trying to solve it. One of the main problems we're having with the specific addiction is how long the withdrawal is, and we don't even have a place to begin to take people through this, if that makes sense.
That makes a lot of sense. Can we do our next slide? Because I think it's going to dive a little deeper into that idea. Well, we can talk, I guess this will talk a little bit about what we're doing to mitigate some of that through our work at the T. Promoting self-awareness of that trauma, understanding that it's not just, it's not just the way it is. It's not a foregone conclusion that life has to be this way. That's one of the key tenets of the work that we're doing at the T, to help people move out of the shame blame game and move into the self-awareness that trauma happens. And that in doing that, we promote conversation to address the stigma of asking for help. Asking for help is really easy when the people in front of you are taking a posture of radical generosity and supporting your capacity for self-care. Mitigating stress by meeting needs and just being there, being accessible, and having a wide range of harm reduction that doesn't just stop at Narcan, but really goes through a wide gamut of resources that we're trying to make available to folks, so that the impact of the trauma and drug use and all the things that go with it are lessened. Marcus, what do you think about what we are doing to address some of these needs?
So one of the main things that I think is instrumental in creating a program that has sustainable success is changing the language and changing how we frame the process of fighting your addiction. What I mean is, it seems to be that it's all negative reinforcement and no positive reinforcement. And there's been a lot of research, put into getting people to accept new ideas, and you can't do it that way. When there's no, reward for the success and it's just constant punishment, they're less likely to stick to any kind of process, regardless of what it is, whether it's drug addiction and learning a new task. Does that make sense?
It does. It does.
So where we
ahead.
begin is even tearing down and rebuilding the language, because that causes additional trauma as well. Or even tearing down the language and the titles in which that we send people into the community to address these needs, because it's a self-replicating cycle of the individuals that are suffering being told that you're not suffering, you need to man up, and that if you do ask for help, there's something wrong with you, and we just have to change all that before we can even start dealing with the trauma. We have to wrap these services in dignity, so they will be accepted and replicated on the client's own free will.
It's interesting in the process of doing outreach, honestly, how surprised people are. Just the fact that we're asking, how are you? Just the fact that we're saying, are you okay? That we're interested in that, and not simply interested in whether or not they're going to partake in whatever particular therapy we have in front of them.
We are, generally, research for Black men, from 18 to 35, they don't like titled therapy. But if you put the therapy tools in a place and let them naturally gravitate to a punching bag, gravitate to a computer, gravitate to some paint, they're more likely to stick to that kind of self-homeostasis training or gathering.
Mm. All right, let's do our next slide. So this is what we started to touch on in the beginning. What do we see as the biggest obstacles in addressing the work? That programs are not what, Marcus?
They're not result-oriented.
So, certainly I'm not a social worker. I don't have a specialty and training in that, but one of the bodies of knowledge we know is out there that so often programs proliferate without being accountable to their actual outcomes, and outcome-driven social resource programs are generally so much more powerful. We're not sure that that model is really the accountability structure that's in place for the multiple different areas that are doing the work, and that there's not a flexibility built into those structures to meet people where they are. That's a term that I've learned from Miles Hoffman, and it sticks with me. I think there is actually one point in this entire set that we're going to share that that really resonates, we're hearing on the street, that Marcus already just said. That's the lack of residential treatment options for those in high poverty with no insurance. Marcus, right now, if you had a friend who wanted to do anything that was in the motion of recovery, and they have no insurance, no capacity to pay for it, and they do not have stable housing, what options do they have?
They don't have any options. We hope that the person administering this care can burn a favor. We hope that they can do something outside of the system of available resources to help this individual in need.
Mm. One of the things also that I recognize in doing my work and dealing with people who are injured is that there's a communal misunderstanding of, or lack of depth of understanding, or an idea that pain is a thing that must be removed.
Mitigated.
And there is no option other than for it to stop, and that drugs stop pain. Yes, they do, but there's so much nuance in between. And so similarly to the way in which our work has been, the idea of bringing to the public life-saving medical knowledge to stop life-threatening bleeding after someone has been shot, I believe we need a public health campaign to help people understand what pain is and what it isn't, and the roles that drugs have in our bodies, minds, and spirits.
One of the main things that we're missing is that a gunshot wound or a drug addiction or an emotional problem are the same exact thing. It's just the physical trauma, we know we need a Band-Aid. We don't see that this person might need some kind of counseling to deal with the stress that their body went through. And then when a person has emotional trauma, we might, deal with what's there in our face, but we will ignore that this person definitely needs wraparound services. Does that make sense?
It does. The absence of the voice of Black men to articulate, Black men and Black people to articulate the needs, the real needs. There is seems to be at times just a massive disconnect between the understanding in the minds and bodies of the people who are immediately experiencing this trauma and those who are in charge of where those funds go. We already said that earlier on. That was something that was said from the last panel, but we can't emphasize that enough. And then another big obstacle to the work is COVID-19. Let's do our next slide. So Marcus, I know what's on this slide, but what do you think has been the most helpful in advancing your work, our work in this space?
Having access to someone who has the medical professional training that I do not have, me being a liaison for that training into the community, and me being mobile, me being able to get it to people who would not be able to put the financial resources into getting it themselves.
It's like we have made the most perfect peanut butter and jelly sandwich. You don't want a sandwich just with peanut butter. You don't want a sandwich just with jelly. We need access and we need resource. We need education and we need generosity. So The T has advanced because we now employ Black men to do the work. We have people who have relationships within community who are well known, who are able to bridge the gap of trust that exists. And we're bringing it literally physically to people on the street with our mobile unit called Tools. We have capacity with what we're bringing. We're not just bringing a bag of chips and a sandwich. We're able to bring more and more. And all of that, the reason why all of that's happening is certainly not because of the T and who it is. It's because of the collaboration with MoNet, UMSL, the State Opiate Response, and hugely Prepare STL, which has modeled for us a way of engaging community-based solutioning by employing people within community. It's a community health worker model for days. I think repetition and reliability, showing up, being the same, knowing where we are, and the calendar and the schedule become our main means of communication. And then having harm reduction and relationship building together. I have spent a lot of time giving out hot dogs. Hot dogs are not going to save anyone's life. But when I give the hot dog, I get the conversation, I build a relationship, and we start getting people who are willing to talk to us and tell us this rich stuff that's going to be key to making the solutions we so desperately need. All right, let's do our next last slide. So where do we need additional help? What do you think, Marcus?
I think that we need to refine what resources that we can use to help people combat their poverty in a residential setting that has a plethora of other services as well. The main common denominator between most of the males in this age group that we're targeting that I seem to have found is that high poverty and lack of resources. So if we can get them here saying, okay, you know, we're going to address your poverty, then we educate them and they realize I do have this other problem. Then they do realize that we do have these resources. It's going to be organic and it's going to be in a way that it's sustainable and it's going to be trackable and it's going to be the way of the future as I see it.
I love that. You know, not everybody who uses opiates or is at risk for overdose is unsheltered and unhoused. But from what I am observing out on the streets, the overwhelming majority of folks has a substantial insecurity in some way, whether it's food, social support, housing, or work. And figuring out who folks are, who needs help, who out there has resources to help, and how we can connect without doing it in a way that's siloed is just so essential.
I would like to elaborate on what you just said. I believe that this drug addiction is from people trying to maintain a balance, a healthy balance. So it's going to be almost a self-fulfilling cycle that when we find these individuals, they just have a certain section in their life where they do not have balance and they cannot find the means to maintain it themselves.
Yes. To end, you know, we know that there are warriors who have been on the front line of this and serving their community diligently for years. And we are so grateful that so many of them have welcomed the resource and the structure of the T and what we do, and me and the team that I have beautifully. We know that there's so many more people we need to meet and learn so we can have the historical perspective that's going to be necessary for future success. Now, not everybody in this work is necessarily going to be friends, and there will be differences of perspective. But if we can align our interests, we can come together in power and really start making the change we so desperately need for our region. Last word, Marcus.
This is a problem that has been ignored for so long, it's festered. The tools that we've used to try to combat this problem are inadequate and archaic. Therefore, it's irresponsible to do anything but something new. Even if we fail, the data that we receive, even if we fail, the footholds that we make in the community can be viewed as nothing but a positive boon going forward. It is our duty to find some way to save this. It's going to be a lost generation of young men, women, fathers. And we want to talk about healing the community. Is that not where it starts?
Well said. Well said.
Thank you
Thank
so
you.
much, Punch and Marcus. We're looking forward to getting back to you guys with the Q&A. Phil, if you could advance us to our next slide. So I am very sad to say that Pastor Pamela Paul is unable to join us today due to a personal tragedy. She is a pastor, an advocate, a SOAR trainer and consultant, and someone I'm truly honored to call a friend. Pastor Pamela has personally distributed nearly 5,000 naloxone kits since July of 2019 and trained thousands of people in overdose education, naloxone distribution, and training in some of the most impacted areas of our state. Additionally, Pastor Pam uses her platform to highlight the voices of people whose stories often aren't told. She's experienced more loss to overdose than just about anyone I know, and yet she still finds a way to push this work forward and encourage all of us to do the work. She leads with love and compassion, and her work is truly inspiring. So I wanted to give a minute to give her a personal shout out and to encourage anyone who is not familiar with Pastor Pamela Paul to follow her work. I'm continually inspired by the work that she's doing and want to encourage others to follow her as well. Next slide, Phil. Next, it's my honor to introduce Wardell Carter. He is the Director of Operations at West End Clinic, one of our methadone clinics in the St. Louis region. So Wardell, I will turn it over to you. Wardell, are you still there?
All right, yes, I'm here. Okay, it's kind of hard to follow up between the two brothers that just got off the mic there, Punch and Hunt.
Yeah.
And, you know, I'm not a man of too many words. You know, I've been doing this 33 years. And there's been a lot of success as well as a lot of failures. So, I mean, my outlook is that, you know, there's been research for the last 33 years, and I've been part of some of that research. And, you know, power, economic power, and, you know, sharing the wealth, pretty much, you know, opportunity, jobs, you know, that'll kind of alleviate a lot of our problems. But until that happens, you know, they're going to flood this neighborhood. I'm in the Walnut Park area. If you all don't know what that is, that's ground zero. I just did a expansion here at West End Clinic, a $2.5 million expansion. So I was able to increase my staff. I went from 5 counselors, I'm at 12 now, and I have 7 nurses, and I'm seeing 600 patients, but we have room to see up to 1,500. So I'm prepared for the need, because there is a need out here for, I mean, right now, we're not keeping stats. We're just trying to save lives. The fentanyl is just so, it's just, you know, everything is cut with fentanyl now. Carfentanil, which is a product that's 100 times worse than, 100 times potent than the fentanyl. I mean, everybody's, that's basically why everybody's overdosing right now, why everybody's dying. You know, it's the fentanyl. I mean, back in the 80s and the 90s, even the early 2000s, I mean, heroin was out in the street and people did heroin, but you didn't hear about too many overdoses, at least not, you know, and I'm on the front line. You know, you hear 1 or 2, but not like it is now. And, you know, I'm just here for questions and answers. I don't have an answer, but I'll give you the best one I can come up with from my experience. And, you know, $3 million is a lot of money to do another study, Rachel. That's a lot of money. I just hope, you know, there's some success with the $3 million. Years ago, we had the URSA project, which was efforts to reduce the spread of AIDS. I don't even think they had half that amount. And, you know, they cut down aides in the St. Louis area. That Wash U project, I mean, it was fantastic. But it just seems like there's nobody doing anything for, you know, the opioid addiction. And, you know, there'll be another study after this study. So, and then there'll be another one after that study. So, am I talking too much?
No, you're okay. I can feed you some of the questions that were from the slides too. We had, what do you see as the core reasons or root causes of inequities in overdose in St. Louis based on what?
There are none. I mean, there are a host of many things, but I mean, there's no one specific root cause. You know, it's a multitude of a lot of things. Yeah, I looked at these questions. I mean, you know, it's you know, there's no, you know, this crisis affects no two people the same. And if you're looking for one specific answer for, you know, to address, you know, if there was one particular answer that we could address this, then everything would be, you know, fine. We'll be able to, we will have the answers to it, and we could eliminate the problem. But it's, you know, it's, I don't know what to tell you, Rachel. It's, you know, like I said, I'm on the front line. I see it every day. I see these people coming in here, despair, you know, no job, no money. Thank God for the SOR. But most people have qualified for the Medicaid until, you know, I don't know, the legislator up there in Jeff City, you know, they got this new thing that just passed in August, the Affordable Care Act expansion. So, you know, that might help a whole lot. But I don't know, you know, I don't have the answers.
I'll ask you one more question. What do you see as the biggest obstacles in addressing the work? Not expecting you to have all the answers, but from what you see in the clinic, what are the biggest obstacles for people?
Right now, after doing the expansion, there is no obstacle. Right now, I'm meeting the need. We're doing anywhere from 15 to 20 new patients, not so much patients that are using the clinic as a revolving door, but new patients that are coming in here seeking help. And, you know, they know that they don't have to pay. And I think that's what turns away a lot of folks. They think that if they come to a clinic, they got to pay something. So that kind of keeps them away. But, you know, word of mouth spreads on the street. They find out, hey, you know, West End is a free clinic. So they're here. And they're taking, you know, advantage of, you know, what we have to offer. I mean, we do the counseling, the family counseling. We just don't give them methadone and send them back out the door. You know, we actually, you know, we're actually trying to help them. We have community support people here. You know, we have people here helping them, trying to find, you know, work, but, you know, what's going on right now with the pandemic, you know, that's really hard to find that. So, you know, we do what we can with what we have, and, you know, we're just staying above board to survive, you know, to see another day, so, you know, we can save more lives. And that's about it.
All right, thank you, Wardell. We will move on to the next slide, and we'll come back to you for question and answer.
Okay.
All right, next I am excited to introduce Riisa Easley. She is the Regional Health Commission Chief of Staff and also one of my very favorite Masters of Social Work teachers that I had during my graduate program. Riisa, I will hand it over to you.
Thank you. And thank you for the invitation. I am really excited to sit on the panel and to have this conversation, this esteemed panel. I'm really more interested in listening and hearing what all the experts sitting here have to say. I'm really inspired and moved by the conversations by Dr. Punch and by Mr. Hunt, and again by Wardell. I appreciate your time, your energy, and perspective, because I think that's what we need in order to really address this issue and moving forward. Can you please advance to the next slide? So we were given the same set of questions to respond to. So I echo the sentiment and all that was expressed in the prior panelists who shared their wisdom and their insight. My perspective will really echo a lot of what you've already heard. And I'm going to start with the experience of structural racism that is embedded, baked in to our systems, which are all interrelated. And what you see happening is that structural racism has led to disinvestments disproportionately in community that then lead to increased disparity in access to those basic needs that all of us have in order to lead healthy and fulfilled lives. That disproportionate disinvestment and inability to access those basic services will inadvertently lead to increased experiences of trauma. There are a lot of studies that have come out in the recent past where we're developing a greater understanding of how the experience of poverty, how the experience of racism in itself creates additional trauma. And so when you have these conditions that are embedded in neighborhoods in disproportionate ways, you're going to then see as a result the disproportionate impact in overdose. The other thing that is really important is thinking about relationships, trusted relationships within our provider communities. So within community, are there organizations, entities, individuals that folks feel a connection to, where there is some level of relationship, where there's mutual respect that can engender trust that allows folks to feel confident in going to seek services and support within the different provider communities. So, you know, as Wardell has said previously, just prior to me, there are a lot of reasons that go into the outcomes that we see today, but for me, those are a few that are top of mind. So if you could advance to the next slide, I'll talk a little bit about what we at the RHC are trying to do to address these issues. Now, we're at a unique position as an intermediary organization that works at a policy administrative level in the work and that we're charged with. A few friends of mine, we often have the conversation about the difference between playing chess and hockey. And for those of you who have been in my class, you've heard this conversation before. And there is a role for both in the work. What I mean by that is there is a critical need for the front line, on the ground, storm the gates, make some noise work that organizations and institutions such as the T are doing to be grassroots, grounded in the community to make this work happen. There is also a need for that strategic chess strategy for those who have access to different boardrooms and executive conversations that allow for some policy change. Where we have increased power is when we start to align our agendas and we're working for the same cause and we combine the chess with the hockey. And so that's the tact that the Regional Health Commission wants to really center its work in. So one of the things that we're doing that's really important for those of you who may not be familiar, we have a gateway to better health. We talked about August 4th was a big day for us, where Missouri decided that we were going to expand Medicaid. In the absence of that expansion, the Regional Health Commission was able to develop a model that covered outpatient services and some medications for people living in St. Louis City and County between the ages of 19 to 64 who were living in poverty and otherwise would not have access to health insurance. Back in 2019, the Regional Health Commission was able to then develop a benefit that was specific to SUD treatment. So making the treatments available for individuals who were experiencing substance use, and making trainings available for our providers within all of our federally qualified health centers, as well as the health centers that are provided through our St. Louis County Department of Public Health. So one of the things that we are directly doing is helping to steward that benefit that allows folks to actually be able to receive the training and to be able to draw down the funds that allows the treatment and the services to continue. We are excited. There's been a lot of, we know it's been a tough year. There's a lot that has been going on. So there have been some fits and starts in the timeline of what we're doing, but we're excited in January to be able to roll out some metrics in response to that as well, to be able to see how many people are being treated, to incentivize folks who are providing this service and intervention, to ensure that that as many people as possible with the resources that we have are able to access these treatments and these interventions. What I would also point to is the phenomenal partnerships that we have and the radical collaboration that we engage with some of the folks on this panel, with folks in the community who really understand and are doing the work. Dr. Punch mentioned Prepare STL, and St. Louis Regional Health Commission helps to steward that project as well. That allows us to be able to listen and engage with community. Oftentimes we might ask a question if we're doing research, but we don't develop the mechanisms to understand what we're being told and translate that into action. And so that's the shift that we're trying to make in saying that we are sharing this space, we are sharing this power, we are understanding that the expertise does not just lie in the evidence, which, you know, as MSW, and I teach this, that we value evidence, we know the critical importance of evidence, but we know that evidence also has context, right? And so if we are just relying on evidence and not taking into consideration what the implications are and the influence of our frameworks and some of the isms that we don't even recognize we're walking around with, then we won't have the appropriate evidence to inform the work that we're doing in partnership with community. So I'll say a little bit more about that. I get excited, so I'm gonna move on. And so what we get to do is to amplify the voices of the folks who are the experts on the ground with the experience, providing direct interventions, those who are in the community, in the clinics, who know real time what's going on, and the expertise of those with lived experience who can then say, no, that's not gonna work. That doesn't resonate with me. And I can tell you because I'm living it. So you can go to the next slide. I'm trying to keep track of my time because you know, y'all, I get excited. Okay, and so what are some of the biggest obstacles that we have identified in the work? One of the things that I think about often and I talk about frequently is the meta narratives that we create about the communities and experiences that we share. If you will recall, we've had issues with substance use since there have been human beings, right? It's the narrative we create about people's experience with substances that inform the level or the magnitude, the attention that we give to it and our approaches to intervention. I found it really interesting that opioids, and I might get myself in trouble, but stay with me and think back to the stories that you've heard and you've been told. Opioids have been around for a long time. People have been struggling with it for a long time. It was when the impact started to touch other communities that the conversation and the language began to change. If you think back to the crack epidemic, and I'm old enough to remember, we criminalized rather than providing treatment. What would the story have been? What would the outcomes have looked like if rather than the criminalization of folks who are grappling with crack could have had the same opportunities to receive treatment, to receive intervention, to receive support, to look at the other social determinants of health that they were working with on a daily basis, just trying to keep their head up, and as Marcus said, to live a healthy, balanced life. right? So the story we tell is critically important. The stigma that we assigned is rooted in the stories that we tell based on, we're gonna go back to structural racism and some of those internal biases that we may not always be aware of. That is what really shades and colors and tempers the work we do, how we do it, where we do it, when we do it, with whom we do it, and if we're able to get the funding and to support to continue it. Okay, so I'm gonna descend from my soapbox and I'm gonna go to the next slide. Okay, so, and when we're thinking about what would be most helpful in advancing our, what has been most helpful, it's again, these exceptional partnerships. It is the folks who are on the ground who know what they're talking about. And to come from a place of knowing that we don't all share because we haven't walked it. To come from a place of knowing that is informed by seeing patients that they serve daily and the heartbreak of families that are really trying to grapple with and navigate their current experience. That radical collaboration that says, you know what? I'm not the expert here, so I'm going to share my power. You may not have had access to this room before, so I am going to go into this room and help to amplify your voice to say, there's a seat at this table that needs to be occupied by these experts who have the knowledge. And if we're not willing to create that space, we're going to find another table and we're going to build it so that we have the right folks in the room informing the solutions to the problems that we're encountering as a community. So for me, when I think about my robust panel of experts, I like to call it, again, if you've been in class with me, I apologize, you're gonna have to bear with me because you're gonna hear it again. There are 4 categories of experts that I feel are required if we're really going to have true expertise and be able to move forward with intentionality and success or efficacy in the work that we're doing. We already talked about how important having the research. The research is critically important. You know, I'm a research nerd. Like, I get really excited and interested in what we're learning from data. That's critically important. But we get that. We already understand that. We need to have executive leadership and buy-in, executive and legislative leadership and buy-in, because we know that policies are informed, written, and influenced in certain rooms, right? So we need to have those folks as a part of that panel to help understand, to inform the work that they're doing. But we also need to have the boots on the ground, the people who can say, I see where you're going with that. I understand what you're trying to say, but here's why it won't work in my community. Here's why it's not going to work with the folks that I serve. Perhaps we should consider. So that's a piece of expertise that for far too long, I believe, has been missing. And then the next piece of it, which in my opinion is the most critical and important piece, the individuals with lived experience. I'm an expert in my experience. You can't tell me more about my experience than I can tell you about my experience. If you want to know what's going to work for me, have an idea, ask me. And people don't always know, and they can't always come up with an answer. Why? Because they're so unused to being asked. So when you ask folks, you typically the first time we'll get a pause like, wait, oh, so you really want an answer. And now, critically important, that bears saying, that I can't, move off of the slide without saying, if you're gonna ask, be prepared to act on the information you receive. For me, one of the pieces of my work that's most exciting is watching the evolution and the impact of Prepare STL, because they go out into community and they ask questions. They go out into community and they just listen. And we will shift and transform and recalibrate based on the information that we're receiving. It is more harmful to ask and then dismiss than it is to not ask at all. And the other thing I will say about that shared expertise, we expect to pay people for their expertise. We will pay a researcher to come and share their research, right? We will pay folks to come and share and drop their nuggets and their knowledge on us, but we expect to go into community and pillage their wisdom and expertise without acknowledging and compensating them. And that has to stop. There has to be shared power. There has to be mutual respect. And we show that by how we interact with community. And then the last slide, because I don't know, I may have gone past my time. I'm sorry, I'm trying to. So where do we need additional assistance or support from the community? We want to continue to partner with folks who are doing the work. We want to make sure that we are continuing to engage in, we talk about evidence-based practice a lot, but we need practice-based evidence. If you are doing research because you find the topic interesting, okay, that's fun. So you'll read it and your whole panel of like colleagues will read it, but it's not doing anything, right? If you're partnering with community, that should inform what the research is so that we develop the evidence so that we can amplify and expand the things that we are finding to work based on experience within community, right? So that experience-informed research, that practice-based evidence. What are we learning from the modifications that need to be made, because this seems like a promising practice or like a gold standard program that we want to implement, but we're noticing through our process evaluation that this is not necessarily working. So what's different? We need to have more information from experience that helps us to refine how we approach community, the work that we do in community. We need to share the power, right? And this is informed by mutual respect. If there is not, go into community when you don't want anything. Shh. Listen. Find out how you can be of service. Find out how you can bring value. Find out how you can serve. And then when you're in a position where you need help or you need to ask a question, you're starting already to build that relationship and that trust. You're starting already to demonstrate, I'm here and I'm not going anywhere because I believe in and am invested in this community. I'm here when you need me, not just when I need you, okay? And I also think that it's really important that bidirectional communication. If you're asking a question, you ask somebody a question, they share their time and their energy, they give you feedback, please go back and just, it's so simple to tell people, what are you doing? What have you done with the information? How has their expertise helped you to move this forward? It's really important to have the respect to come back and share that feedback with the folks who are sharing their time and expertise, which is really valuable. And then there needs to have some infrastructure and capacity building resources. As we're sharing this power and as we're thinking about this work moving forward, the most powerful work is that which centers power in community so that the community no longer needs you to do the work, right? So work yourself out of a job, right? And think about all of the disinvestment. Think about all of the structures that were built up over time, well before you and I were ever on the scene. And think about how you can use your power, your influence in this opportunity to dismantle some of those structures, to allow more access to those rooms, to decision-making, to the agenda setting and planning, and to have something left behind so that individuals and communities can continue this work in response to the need that they're identifying and experiencing without having to rely on and always count on someone to come in and do it with on their behalf. So those are my thoughts that I'll share, and then I'll drop the mic.
Thank you so much, Riisa. We will be back to a question and answer shortly. Phil, if you could click to the next slide. Our final panelist today will be the Director of the Missouri Department of Mental Health, Director Mark Stringer. So I will turn it over to you.
Thank you very much, and thanks for having me. I'll tell you, if you Google hard act to follow, I think you'll find Riisa's picture there. Next slide, please. So answering the same questions, and of course, this has been going on across the country, some places worse than others. St. Louis has got a severe problem, as everybody on this call knows. Root causes, just to get right at it, concentrated poverty, lack of housing, disinvestment, generational trauma, and limited access to healthcare and employment. Those are what I would call the root causes. And Wardell, I agree with Wardell that it's a multifaceted problem, and some of those problems are tough to address. It's been made worse by the pandemic, and certainly the increase in fentanyl, and that has caused, of course, most of the deaths. There's also limited access to treatment, and poor strategies, with some exceptions, but poor strategies to try to get folks to engage in treatment. Next slide, please. So we are, in DMH, are committed to addressing certainly inequities within our system. When the most recent protests were going on, somebody asked if DMH was going to put out a statement. And I said, I don't think anybody really wants to hear what Mark Stringer has to say about this issue, but I think people do and should care what Mark Stringer is going to do to make things better. If there is any way to make things better, how can he do that? And so I wanted our response at DMH to be action. And so we established this Mental Health Equity and Inclusion Alliance. We hope to build the capacity of communities and neighborhoods. I think it was, Riisa talked about partnerships with existing programs and services, sorry. Targeting the neighborhoods where we're going to have the greatest impact. So we're doing some fairly quick analysis now of where most overdose deaths are happening. We probably don't have to look too far. I'm sure Liddell can point us to where they are. And then coordinate efforts with efforts that are going on right now, and then targeting the harm reduction strategies, peer services, timely access to good treatment, and commitment to having good outcomes. So the second bullet point above, I wanted to say that we know that we can't solve the St. Louis overdose death problem from Jefferson City. We're not going to solve it. It's going to be a local solution. Our job is to support it, however, and we will do that. Next slide, please. Biggest obstacles are things that DMH will not be able to tackle, or will help if we can, but concentrated poverty, that's a tough one. Insufficient resources like transportation, housing, treatment, employment. Timely access to treatment is a problem, either because the programs are full, or because the programs, may be operating on a 1970s model where it wasn't urgent to get somebody into treatment. And then resistance evidence-based treatment because of outdated perceptions. People believing, for example, and there are a lot of these people who believe that treatment is 30 days in a residential program. And I'm not bad-mouthing residential programs at all, but there is a full spectrum of services with which we can reach people. And that's going to be the key. So next slide, please. Most helpful so far has been all the federal grants coming in, the state opioid response grant that Wardell referred to, and certainly partnerships has been helpful. Partnerships with law enforcement, partnerships with social services, partnerships with employment services, things like that make a difference. We have within DMH smart, seasoned professionals that are guiding our efforts in this. People like Joe Yancey, Mark Miller, and folks like that. So, and we have all of us, Laurent Javois, we've all worked together literally for decades. And so we decided that, and we're all getting old. And so we decided that this is on our bucket list to do something that's going to make a difference. And I have the full support of the DMH leadership team as well. Next slide. So we need what we need is partnership with the communities that we're focusing on, because again, we can't solve it from Jeff City. And then we would work together on solutions alongside those people with lived experience. And then just a willingness to work together for a straightforward objective, and that everybody can get behind, and that's simply to reduce the number of overdoses among people of color, and especially Black males. And I think that is probably my thing. Okay. Thank you.
Thank you, Director Stringer. Phil, if you will advance us to the next slide, we are going to move into the question and answer portion of this webinar. I am trying to follow all the questions that are being submitted here. I'm going to just start with the questions that have been upvoted the most. So make sure that you are paying attention to the questions that have been entered in the question and answer box, and to upvote the ones that you want to be asked. So I'm going to start with the first question we have here is, what do you plan to advocate for in the next legislative session that could help address racial inequities and overdose deaths? And I am going to start with Dr. Punch. We'll just go back in the order that we had.
I'm not sure I'm the best one to answer that question. Can I?
You want to pass it along?
Can I have Riisa answer for me?
Sure. Go ahead, Riisa.
Happy to take that one. I'm really excited about the new approval and strategic priority that the RHC has taken around policy and advocacy. And so one of the things that we are working towards is building sustained relationship with our legislative partners, both locally, so, you know, from our alderpersons and our council people, to our state senators and representatives, to ensure that we understand what the agenda is and that we're able to convey what our needs and concerns are within this community. And so again, that partnership comes really essential so that we can help to advance regional priorities and agendas and partner with our legislators across the aisle, because it takes all of us, y'all, to do this work. So how can we partner in ways that are meaningful and move this forward? So we take your information, and we're actually currently doing this. We had a couple meetings just in the past couple weeks where we've been saying, here's the data that we're seeing. Here's why it's important. This is what's important to our region, and how can we partner with you to start to move forward? So we're going to continue to share information as it comes up with all of our partners so that you can engage and inform us. We have the first thing that's coming up will be in mid-January, where we're going to have a healthcare town hall, and we're going to talk about some of these very issues. And so we'll share again that information and hope that you will continue to inform the conversations and the questions we need to ask and the advocacy that we need to continue to promote.
Thank you, Riisa. Marcus, did you have anything that you wanted to add as far as legislative things that need to be pushed along?
I would, can you hear me?
Yes.
I would push for the expansion of Medicare and the expansion of medical services to high poverty individuals. And I would push for the change of the legal language of how we identify what would be a person suffering from this affliction or a person that might be privy to these programs, if that makes sense.
Yes. Thank you. Director Stringer, what are DMH's priorities this upcoming legislative session?
There's a couple, and not necessarily new legislation. Now we would absolutely support new legislation if our team identifies new legislation that would make a difference. We would definitely do that. You know, our focus is normally on funding. This field that we're in, that I'm in, and Wardell's in, this field has been so underfunded for so long, and there simply are not enough treatment providers. Certainly in St. Louis, there are not enough treatment providers. So there are two things on the horizon that give me hope. One is the feds know that there is a significant problem, and they've recently they've put out these state opioid response grants with a substantial amount of money. There are a couple of bills at the federal level, proposals that would add $1.5 billion to the substance abuse block grant. That would be quite a shot in the arm. There's also Medicaid expansion on the horizon. That's going to make a huge difference. And so what we're going to do, sorry, this is a long-winded answer here, but what we're going to do is, you know, not just spread these funds all around we're gonna try to be precise in where we put funds and new services, and again, in places where it's really going to make a difference. And so, and we will need help from the community, from folks who are more familiar, who are on the ground, and we will ask for that help, so that we can use these funds to the best of our ability. And that's it. Thank you.
Thank you. I'm going to follow up that question. There's another question in the question answer box. It says, are there any efforts to include additional funding for addiction services through the state budget, like naloxone, treatment, recovery support, to create sustainable funding outside of federal grants?
Well, yeah, it's a good question. If it goes, well, two things. One is, of course, the state, like all states, has been rocked back on its heels by the pandemic. And the budget is really tight right now. And so if these federal proposals come through, they go into the block grant, then that's permanent funding. And aside from that, you know, whenever it looks, I have to be careful that that we don't lose credibility, you know, by asking for funds where they're simply not there. And so, but every chance I get, believe me, I will. And we need more prevention, treatment, recovery, and so on.
Hey, Mark, I talked with Corey Bush a couple of weeks ago, and she came by the clinic. We had a 2-hour discussion on funding, and she was telling me, you know, she was asking me, you know, was there anything she can do to, you know, push more funding into our opioid crisis. She mentioned the CARES Act and some adjustments that could possibly, you know, go into that in order to get us more money. If you can tell me what you need or I mean, I have a direct line to her. So
well, yeah, thank you for that. I will definitely get with you after the call. Thanks.
You know I'm political too, right?
You bet.
Okay. All right.
I've known many political Carters, yes.
Thank you.
Okay, moving on. I think this is a question for everyone. How are you addressing, oh no, okay. How are you addressing the intersection of COVID and overdoses in the Black community? Punch, do you want to start with that one with your guys' work?
You know, for us, it's the overlap of COVID, overdoses, and bullets. And I think one of the key things is making high quality, relatable information as available as possible in collaboration with people who have relationships with the people who need stuff, right, within the Black community. So that's the T has been part of the Prepare STL model. And one of the reasons why Marcus is, for instance, on Team T is because Prepare STL supported us first to get COVID support out to a wide range of communities. And Marcus, being an advocate for those who are unhoused, was a natural fit to be part of that campaign. And so in a way, in this really bizarre way, in the midst of unspeakable tragedy, COVID has actually ignited and advanced the reality that we need to get a lot of information, not just about the virus, but a lot of public health information in the hands of folks who need it. And so now what we're doing, and what we started doing, we started bringing out Narcan with us while we were doing mass distribution. And now mass distribution is part, and PPE and other information about the virus, and just checking in with people and seeing how they are, even making availability of testing. All of that is inseparable from the work that we're doing for harm reduction. But I think the bigger issue and the hunger that I have right now is to better understand why bullets and a virus and a molecule all have such a profound effect in the lives of Black folks in this region. And where they intersect, where they come together, allows us to gain power to act, because it's where funding streams can also interact. It's where communities of aligned interests can interact. It's where a lot of focus can come together. So now I no longer think of any of these things in isolation. And our work, we never bring one without the other. And I really am excited about how that sort of, as Marcus says over and over again, wrap around, that's one version of what wrap around can mean. It's not about overdoses, it's not about homicides, and it's not about COVID deaths. It's about the health and well-being of Black people. And that is really exciting to be able to focus on that, even in the midst of unheralded, never before known, at least in this century, tragedy.
Yes, thank you, Punch. Does anyone else want to add? Marcus.
Can you hear me now?
Yes.
So for me, it's almost like a duh moment. As you know, the work I was doing was incredibly poverty-based. But one of the main things that causes poverty is lack of access to health resources. As I'm out here disseminating information to get people to survive, the COVID pandemic hit, and I became the medical professional for my community, and I realized I was woefully undereducated. So I had to educate myself and to begin disseminating an entirely new packet of information with the stuff that I already had. Dr. Punch was the only person that came to give us the actual physical tools we needed to keep safe outside from educating ourselves. And it made me realize all I'm doing is for naught if I can't give people a simple mask. Dr. Punch had wanted to help, had wanted to be invested in the community for a while, but how could she do that in an effective and in a natural way when these people don't know Dr. Punch and don't have a trust for anyone who came out here to administer the services? So you almost can't have one without another, because I'd be running around in complete ignorance when a problem occurs that I have nothing to do with. Does that make sense?
Totally. How that partnership and community, bringing people in from the community with the healthcare knowledge and bringing that into the community is so needed and so powerful, the work that you guys are doing.
So I'm centered to the immediate need, and I'm centered to the immediate lack of services. I'm not centered to what's available in the work that people are doing to try to increase the services until now. I've done research about kinesthesiology. I've done research about addiction, about how people handle trauma, all sorts of things that I would have never thought that the community needed. And it's so incredibly ridiculous to me that how could I be doing this work and saying that I want to heal and help people, and I haven't even thought about one of the main causes of trauma that I inherently ignore. So we have to start there. How can we not start in equipping people with a plethora of wraparound services to begin to give people, because they're going to want to meet their most immediate need first. Whatever their immediate need first is going to activate their drug addiction, it's going to activate their poverty, it's going to activate their depression, it's going to activate their negative mental health. So we have to have a tool belt full of all these things so we can stop the immediate need and then begin to stem the needs that are going to be additional. Does that make sense to everyone else?
Yeah, totally.
So my entire understanding of how we can actually heal this problem instead of putting a Band-Aid on it came from the partnership of dealing with Dr. Punch and the T and Prep STL. And by and large, how we packet these services and give it to them. You know, a lot of people are scared to say, we're just going to put it in the bus and drive down there and educate people, but that's what it takes. Or even if people do have the moxie to say, we're going to educate people, how do you get people to accept the way that you disseminate this information when you can't even articulate it in a way that they understand?
Thank you, Marcus. Riisa, did you have something you wanted to add?
If I may, I want to go back a little bit to what Dr. Punch mentioned around the intersectionality, because that's something that I think about a lot. I believe that this moment gives us an occasion to understand how our systems are structured in ways that are unjust and harmful to Black communities. So COVID gives me a concrete example to demonstrate how our systems are devised to put a disproportionate burden on Black communities without then coming with the requisite amount of resource and support. COVID just lays bare the issues that our system has had since inception. And so it's an opportunity for folks to say, okay, I see it here, because now the movement is ripe. and people have more of a willingness and openness to have this conversation. So it is from our seat, our responsibility, right, to seize this moment for it not to be in vain. Because for generations, too many Black people, too many brown people, too many folks that were replaced as society, the global we, on the margins, have been dying because we were unwilling to recognize how our systems were perpetuating this injustice that created in these outcomes, these unjust outcomes.
Yes, thank you. Thank you, Riisa, for that. Okay, Wardell, did you want to add any thoughts about how treatment centers are addressing both COVID and overdose collectively?
Well, I mean, treatment centers and, you know, we're right now we're a 3-day operation, and we're trying to keep our staff safe as much as we're trying to keep the patients safe as well. But I really don't have much to say on that.
Okay.
We're just doing what we have to do to survive until a vaccine comes along and everybody's okay.
All right, thank you for that. I will move on to our next question. Director Stringer, this one is for you. What is DMH's relationship with law enforcement, and do you have any plans to change it? You're on mute.
Yeah, I've only done this for 9 or 10 months now, so give me a break, will you? I'll pick it up eventually. What I was saying was, before I answer that, is that Riisa, your response to that last question was brilliant. I had not put it in that context, but it was brilliant. So thank you for that. I'll be thinking about that for days. Okay, so with law enforcement, we've got a pretty darn good relationship with law enforcement. Of course, it's better in some places than others, but we've got a number of projects going on with law enforcement, including CIT, crisis intervention team training, where people learn how to talk where officers learn how to talk to people with mental illness or substance use disorders. We have what are called community mental health liaisons that work strictly with law enforcement to help address, again, people with mental health issues. We also participate in training. One day we had we have a big conference room here at DMH, and one day that room was full of highway patrol and other law enforcement officers that were learning about Narcan. So yeah, we've got a pretty good relationship. You know, again, if there is something in St. Louis that we can do that we're not doing, you know, we will find that and figure out how to do it.
Okay, I'm gonna follow up that question a little bit with it in St. Louis. I guess in the nation at large, there are obviously tensions among many people in their interactions with law enforcement. So I guess with that question specifically involving law enforcement in some of these overdose revival or bringing in CIT, is there any plans for changes to mitigate those interactions going forward for individuals?
Oh, I'm going to have to think about that, Lauren. Yeah, I'm going to have to think about that.
I can make a comment.
Thanks, Punch.
We know for a fact that there is tension in the St. Louis region around law enforcement acting as first responders. This is an issue I have personally discussed with a number of leaders and officers, and the statement I get back every time is we enforce law first. That creates a primary obstacle when the people who are often called to respond are, or the people who are most proximate to these emergencies are law enforcement. There is a movement and an awareness that there needs to be a, not simply along with law enforcement, because as soon as you go, and I'm using David Dwight's language here, this is not my own, but as soon as you go with law enforcement, as soon as it's couched in that way, no matter who's in the car, no matter who's riding along, it's still in that framework. But instead, there needs to be an emergency response that is staffed, run, and based on attending to those specific needs outside of, outside of law enforcement. And so I'm really excited about the development of behavioral health, social support, and along with it, issues that go around substance use, and developing an emergency response system that is not based in law enforcement. Because I think you cannot reconcile everything we just said about the roots of the issue of opiate use, overuse, misuse, and death from the structural racism inherent in law enforcement. You can't separate, you don't get a pass on that, right? And so I really think this question is a fantastic one. And it's an area where other cities, right, have really already done this as community-based effort. And I'm super excited to know that there are people in St. Louis who are interested in these kinds of answers. I'm personally want to sign up to be on that team, because that sounds like a really, really powerful way to address the issue.
Thank you, Punch. I'm going to move on to our next question. How can we hold white recovery and treatment service providers accountable for racist behaviors, words, and actions? People who are new in recovery typically aren't comfortable advocating for themselves, and the current system to hold people in power accountable does not work. Who wants to take a stab at that one? I'll start with Director Stringer. Are there any mechanisms through DMH that are available for people to hold different providers accountable?
Yeah, we have certification criteria. We have contracts. We've got a variety of ways. But I think that what the questioner is getting at is, this is happening, and we have not done enough to address it. I think that's a fair statement. And now, again, so all providers are not created equal. Some treatment providers are really good. They're trauma sensitive. They are trauma informed and respectful of people. So, and then others less so. And so when we're made aware of those things, or when we find it during our certification surveys, for example, we will address it, and may require someone to be on an action plan, a corrective action plan that is convincing, that's real, and then we'll follow up to make sure that they did do what they said they were going to do. So that's I'm not sure that was a good answer, but that's about the best I can do.
If I could make a comment that's highly informed because of the experience I've had with the issue of treating people who've been shot. Aside from the behavior biases within the individual providers, the way we treat people who have been shot is inherently and horrifically racist. Everything about it it creates an outcome that worsens the experience of Black bodies and Black men. Opiates, I think, are really no different. And one of the things that I have had to do as a health professional is release completely. Even like me, I have to release completely everything I've learned to think about how I treat the injury that a bullet creates in order to really hear what I had been hearing from my patients for years, but did not have the power to listen to and act on that action that Riisa was calling us to. I think the same thing has got to be deeply embedded in the way we think about diagnosis. Marcus said words, what we call it, people who are not living the lives that they want to live because of opiates. Because I think we have to actually totally dismantle more than just the personal bias or the inherent issues or overt racism and lack of a trauma-informed approach in individual providers, and recognize it's in everything we do. I don't care how woke you are, you can't avoid it. And so I'm really interested in us, again, if our outcome, let's say when it comes to the issue of homicide, is to reduce crime rather than to promote equitable public safety, we will do a wildly different thing. If our hope with opiates is not to promote the health and well-being of Black people who use drugs, but instead simply to reduce overdose deaths, y'all hear me? I mean, I'm gonna say it. I'm saying it. I guess I had just said it. We're not gonna get there. We have to dismantle and decolonize that language to really get forward, because even the most compassionate, trauma-informed, clued-in person will be constrained by a system that doesn't allow true healing to occur.
Yes, thank you, Punch. Anybody else want to add to how to hold treatment or recovery housing providers accountable for racist words, actions, behaviors? Okay. Moving on to our next question. What role does the criminal justice system play in perpetuating inequities and overdose deaths, and how can we change it? Anybody want to start on that one?
I would say that, am I loud?
You are.
Okay. I would say that if an individual is young and then find themselves in the criminal justice system, a lot of the times they're not going to get a diagnosis of something wrong with their mental state, if that makes sense. As per a person who might have access to, a psychiatrist or someone who might understand, there's something different or wrong, or that a person doesn't have access to, again, a good access for their trauma at a young age. So it's a perpetuating cycle. Does that make sense?
Yes. And I think a lot of the things that we've mentioned, that have been mentioned so far, right, there's a lot of intersection here. The criminalization of drugs obviously leads to people getting treatment or people being jailed. How can we change that? Does anyone want to take that?
The currency that I deal in and that we deal in is really in partnership, right? So that relationship building. One of my favorite roles, and I think the most important role that I've played in throughout my career, has been the amplification of voices, right? So folks who know and can speak truth to power in these spaces, to be able to open up the dialogue and the communication, and to be able to influence, right, and inform policy agendas and change. And then to develop on the other end, from my academia perspective, measurements to hold folks accountable. So when we have these conversations and folks are making promises, what are the measurements that we have that we can look back and say, now here's what you said, and now we can show you what you did? And so I think what's often lacking that allows these systems and inequities to perpetuate is accountability. So there has to be a way for us to be able to measure and to transparently communicate what is and is not happening, to understand who is bearing that responsibility and how the community that you are serving, right, and to whom you respond. What levers do we have to pull to say, you know what, this is what you promised. We are the community that you're serving, and here's where the accountability lies. So what are we going to do about it? We don't have enough of that. We don't have enough accountability built in.
Punch, did you want to jump in? You look like you're thinking. I don't want to cut you off.
I am thinking the overall framing of this is, maybe this is too simple of an answer, but I saw it in the chat, and it's something I've learned from Chad Sabora, which is the historical drive to criminalize substance use, right? That's like 13th Amendment level stuff right there, right? Okay? It's like being black is a crime. And anything that can be associated with blackness can be called a crime. I mean, if we don't, well, I guess we don't, we got to start by talking about it, right? We have to admit that they're, just like Riisa said, drug use ain't no thing, ain't no new thing. And in fact, there's a lot of versions of drug use that can attach and allow human beings to achieve higher function, higher forms, higher consciousness. Y'all had your coffee today, don't play like you didn't. And there's these little places called bars where people like to hang out with this when COVID's not rampant. So just let's just be honest about it. We're criminalizing something in a way that allows us to maintain the disenfranchisement and the use of law enforcement to perpetuate the historical and economic realities of slavery.
Yes.
And so, unless we can have that conversation, we can't really move forward. And one of the things, again, I feel like I didn't want to say anything I was thinking, because I'm like, I'm just going to say the same thing again. But that's why it's so important to have new eyes, new structure, just dismantle, radically listen, and problem solve and solution in a way that we've never done before. I do actually think there is a different way to do this. And I'm excited for all that I'm learning about how we can do things differently.
Yes, thank you, Punch. Moving on, this next question says, while working on a study with peer recovery coaches of color in Boston, I got to see the amazing work they do in making this sandwich work so well. But I often found pushback from administrators at the hospital and other physicians and researchers who were unwilling to collaborate because they had concerns of professionalism, that's in quotes, from coaches, which to me was a code for they weren't white enough, or claims of not enough evidence. How do we respond to this?
Okay. I think that goes back to Dr. Punch's comment about seeing things with a different perspective. We are socialized to assign value to different things. That comes from someplace. So there is so much, to borrow Dr. Kira Banks' words, appropriated, right? Racism. Like, we internalize this stuff and we assign value to how a person dresses and how a person speaks and the language. The fact of the matter is, if you look at what you've been doing thus far, it has been completely, well, not completely, but it's been ineffective. We wouldn't have the numbers if what we were doing was working. So now you are trying to take something that is working, and part of what's working is who's doing it and how they're doing it, because they have authenticity and relationship and community. But you're saying, yeah, we want you to do that to make our outcomes look better, but we want you to do it the way we do, but what you're doing isn't working. So we have to get to a point where we're first able to acknowledge where this discomfort is rooted, where it's coming from, and the structural appropriated racism that comes with it. And to be willing to then say, you know what, maybe that's not what's important. Maybe I'm majoring on the minors. I'm focusing on the wrong things. and to allow space for the experts to be the experts, how they are the experts in the spaces where they are the experts. Because side note, that's why you need the help.
And I'll just add in what Riisa said earlier too, making sure you're paying people at the peer level. If you're considering them an expert, pay them the expert level that you would pay anyone else if you're bringing them in to do that work. I think that's so important, and especially for peers, creating a trajectory in which their career can advance and they're given those same opportunities as we would anyone else that we're asking to do the work. Moving on. Ooh, Marcus, jump in there.
Real quick, it's going to be instrumental that we do, you know, empower people that are able to bridge the gaps in that way. Like, you know, it's interesting that, again, I'm thinking about legal language and how that impacts the way we serve people. You know, I'm thinking about the medical implications of how we serve people. And it's just amazing how incredibly more effective I can be when, you know, someone pays me a steady salary and I can give a problem 40, 50, 60, 70 hours a week or however long I'm willing to work at it, instead of, you know, me working around a different job. Or I'm an individual that's been doing this kind of work for a decade plus, and it's good to get some kind of steady, stable living situation, or, you know, enough stability that I can actually focus and I feel like do something that's more than give someone a sandwich, give someone a bag of chips. I can do something that's backed by research and that can, you know, be enhanced by the work that I've done, that I can actually, in a way that I see the results in the community, you know, my effort is counted in the research and in the numbers, and it's just a different kind of world. It's a different kind of thing, and I think that what we're doing now is a big part of the solution going forward, is just getting all these people in the room together so that we can collaborate better and understand the full 360 and wraparound scope of all the things we're doing.
Totally. Moving on to the next question here, we have, how is affordable housing being prioritized, and how are you addressing the needs for the people who are unhoused? Dr. Stringer, if you're talking, you're muted.
Someday I'll figure this out, just not today.
You got it.
Yeah, you know, this is one of those absolutely critical issues that we don't have a good answer for. We've got some answers. You know, we get about, I don't know, it used to be $11 or $12 million from the feds to support affordable housing, but that's not enough. And there's not enough. Oops. There's not enough housing stock either, and that's an issue. So the feds now have become more willing to let us use treatment dollars, for example, for housing, not to build houses, but certainly to pay for rent and things like that. We do have some places around the state that have got some interesting models. There's a place in Kansas City called Amethyst Place, where ladies in recovery can go live for up to a year, I think it is. And they all have their own apartments. And when they move out and get their own apartment elsewhere, they let them take their furniture with them. And I thought, well, you know, that's really a nice touch. They don't have to start over that way. And then that furniture is replaced by local businesses and things like that. So, you know, that kind of a model really works. And and that's also an example of where we need, you know, this will have to be a partnership with the communities that we serve and with the businesses in those areas and so on, to create those kinds of models that are going to work, that are going to make a difference.
Anybody else want to jump in on that, on the work that's being done with people who are unhoused, what they're seeing, what should be prioritized?
Housing should be first. It's impossible to have any kind of sustainable service program, any kind of sustainable contact, anything that's permanent, anything that's going to be life altering or results oriented, unless the person is stable. You know, How do you give someone a phone if they can't keep it safe? How do you begin to give someone a wardrobe so they can be professional if they can't keep it safe? Basic needs have to come first. It's basic.
I want to just amplify what Marcus said. It's so simple. You know, it is heartbreaking to be doing outreach with Miles, with Mer, other people who are on here, and have people tell that they went to Chicago because that's the only place that they could get some kind of treatment, but it was so hard for them to be away from their family and their community. I mean, that's what's happening. The people have to go all the way to Chicago. It's like the only option for people who are in high poverty, uninsured, if they want to both address the issue of housing and residential treatment at the same time. And the other thing is, I think, you know, I asked a little while ago, I don't think we really know what the numbers are because so many people are sleeping on someone's couch. And that's a really hard place to be when you're going through what might be the toughest battle you faced in your whole life. And so it's not just folks, not just housing, but people who have found a way to make it and all the compromises that they have to do to be safe. How many people are in the situation they're in, and how much is drugs in the equation for them to be safe, right? And so it's yes, 1000% what Marcus said, and we have to do more to find out what people really are and what they really need. Now you could say, right? You could say, well, dude, that's anybody. That's anybody who needs housing. I mean, housing is a problem. Low-income housing access, yeah. But I feel like I'm going to call the language of this discourse into accountability and say, if this is about people at risk for death, not just at risk for not having the shoes they want, not just at risk for not having the exact food choice they want, not just at risk for having a child that's struggling with school, I'm talking about being dead. Then we do need to get radical in our solutioning around the issue of housing. And I feel like, in my humble opinion, it's more than an issue of money. It's about people being willing to deal with the liability of having someone in their house that they're responsible for and might overdose. I just said it. And I know there's somebody, pastors on here who, and there's a lot of people, I think, on this call right now who are willing to take that on and are struggling to do that work and are standing in the gap where there needs to be a state, federal, city, big solution for how we can keep people safe when they're not yet in recovery and desperately need that kind of help.
Yes, Punch, thank you. Next question, how can we remove the financial barrier of accessing care from outpatient MAT programs, inpatient programs, detox, etc.? It's nearly impossible to get folks who need higher levels of care their appropriate care because of wait lists and not having insurance.
I think that it begins with either a different way of funding these things that's community-based, either activating the community to do some sort of mental mutual aid fund, or radically changing the way that we administer these services and saying that, you know, we're going to find professionals that are willing to do this work, and we're going to find a way to pay them that, again, is some way different, because the most important thing is that we get these results.
Yeah, and I always say, I agree very much. And I always say that, you know, every name on a waiting list is a potential death, and we need more. Now, again, I'm optimistic that the feds with their grants that appear to be sticking around, and more importantly, Medicaid expansion is going to put more resources into our system. We've seen that happen in our neighboring states that have had Medicaid expansion. In fact, we've lost a lot of clinicians across the borders because they can get paid better, and then there are simply more resources. So we will be able to enjoy some of that here, and I think, you know, so even if we have more treatment services or more treatment capacity, our biggest challenge, I think, is going to be just the workforce. We don't have enough clinicians, we don't have enough doctors, nurses, counselors in this business, and the only solution, I believe, is what we talked about already, and that is the use of peers, people with lived experience, paying them a fair wage, and entrusting them to do more than, you know, make copies or whatever, or transport people, but actually give them meaningful work to do where they are making a difference in people's lives.
I'm going to follow up that question with another question that says, how could a treatment agency that serves in North St. Louis get a DMH contract? If there are individuals out there who want to do this work in the areas that need it, how could they go about getting a contract with DMH?
Yeah, the first step would be to become certified by the department, because by law we cannot provide funding to any agency that is not certified by the department. So that'd be the first step. And we do have agencies that are certified that are not contracted by choice, but they want to be certified, which is fine. So that's the first step. And then secondly, I would say to the person who asked that question, stay tuned, because, you know, again, Medicaid expansion is going to be a huge game changer. We don't know exactly what that's going to mean in terms of the kinds of resources we have, but, you know, from everything I hear and everything I know, we do not have enough treatment services in North St. Louis. So stay tuned.
You know, I just want to follow up with that because I went through the experience over the last 2 years of trying to develop a clinic for people who have been shot and were at risk for being shot again. Just like with overdose, one of the most biggest risk factors, right, for dying is prior overdose. Same with being shot. One of the biggest risk factors for dying from being shot is having been shot. And I will tell you, the experience of trying to create accessible, free, no strings attached, relatable, generous care within any kind of medical healthcare system as it exists I was unable to do it, and instead had to step out of the healthcare system as it exists to create a clinic with the help of the Regional Health Commission called the Bullet-Related Injury Clinic. And what it taught me, and what I think we are going to be learning about opiates, is even Medicaid, right? Even what we think are low barrier, right? Healthcare options don't get people in the door who have been historically and horrifically unreached, not unreachable, but unreached by the systems that exist. So I really love the idea that the state and you know, Mr. Stringer, I love what you're saying. And I also, though, want us to question even those apparent safety net structures, because I'm not sure they are prepared to have a low enough barrier to get people in and to keep them in. So just, I'm really excited that we reimagine, even as these kinds of ideas move forward, what that looks like, what the licensing requires, who can say how it should be. Because I think it's fair to say, I know when it comes to what I've seen around the issue of bullets, we're failing. And I think we have some significant concerns about what's happening in the world of opiates. And I just want us to be ready to answer the input we get from the community. And in as response to something Wardell said earlier, $3 million is a lot to spend on another study. And if anything I have to do with it is not going to simply be another study. And that's this conversation and actioning these kinds of solutions is what I'm hoping can come out of that work.
Yeah, that's really well put. I appreciate that. And that is, in fact, part of our conversation right now. with people like Wardell and others in St. Louis, you know, what can we do different to actually engage with the people who need our assistance? What can we do? It's not what we're doing now, but what can we do? What different? And we are intent upon being to get there. We can change rules, we can change contract terms, we can do a lot of things to do things differently and creatively, and that's our intent. So thank you. That was a very good statement. Thanks.
Yeah, I love that, and I just want to echo hockey and chess, y'all. There are different strategies. My grandma used to say there's more than one way to skin a cat. I don't know why we're skinning cats, but I will say that there are different approaches. There is so much creative idea and energy in community. Folks that have had ideas and they just need the resources and support to bring it to fruition. We have to do a both and. We have to work from both directions. While we are encouraging, demanding our systems to be different and more equitable and holding them accountable to that equity, we also have to find ways, again, it's that shared power. We have to find ways for more participatory budgeting, where communities can use the knowledge, the wisdom, and the relationship they have to activate these ideas that we know will provide, well, we may not always acknowledge that we know it because we feel like we need to research something to tell us, but we know for real that this is what's going to work. So how can we get out of our own ways, right? And provide the resources and support that community needs to implement the solutions that they've already generated through their creativity and relationship, while we hold our systems accountable and push for the transformation that must happen if we're gonna see more equitable outcomes.
It begins with highlighting the people in the community that have been doing the work, backing the work with research, and then extrapolating the research and the results from the work that they've been doing in the community, and framing the finances in a way that they get to the people that are providing the resources. If we do it in a natural way where the most fit survive and the most fit get the resources, it's going to weed out the people that have ulterior motives. It's going to weed out the people that are impeding the success of the general natural community.
Thank you, thank you. I think I'm going to end our questions on that and move to some closing remarks. I wanted to close with some direction forward, and I don't think I can say it better than anyone, better than Cassandra Frederique. So I'm going to share some of her words from a letter she wrote as she took on the role of executive director from the Drug Policy Alliance. She says, "I'm stepping into this moment with the understanding that to expose and extinguish the drug war, we must redefine it. To be clear, ending the drug war will always be our focus at DPA. But we enter our third decade of work. We must remember we cannot fight against the drug war as an end unto itself. Rather, our work must be informed by the layered, intersecting injustices faced by people and communities we work to support, and follow the leadership of those most impacted by the drug war itself. Groups disproportionately targeted by drug law enforcement, particularly low-income people and those of color. At DPA, we're going to emphasize this interconnection, shining a light on the drug-related policies that hold us all down while doing the fundamental work to lift us all up. We know that a piecemeal strategy in the fight for freedom has only left the most vulnerable in our communities behind. People who use drugs need everyday health care, not just treatment. They and their families need housing and food just like everyone else. They need communities that are thriving with plentiful jobs and top-class schools, just as everyone else does. The drug war, through its policy, twisted drug war logic, and its aim to dehumanize our loved ones, limits the resources people need to be full participants in society. In this fight, it's our duty to reimagine policies, push forth logic grounded in truth, and create pathways that serve as the enablers to the actualization of full participation. Victory is far from certain, but I know that progress without a final full ending to the drug war is empty. I know that a moral war fought on narrow policy successes is doomed to the margin. If this year has taught me anything, it's that the fight for an ending can feel endless. That's why I want us to fight for an ever after, one that's limitless in possibility. Yes, it's time to end the drug war, but as our comrades on the front lines fighting against police violence push us to remember, it's also time to build the world after. We can do them both, and we must do them now. I'd like to thank our panelists for the work that you're doing and for your willingness to share. Thank you so much to our attendees for showing up, asking questions, and creating a robust discussion. And thank you to all of you who will go back to your work and dive into creating the world ever after, a world that's equitable and just, that provides accessible services in a comfortable manner to all those who need them, and a world that liberates all people. Please stay tuned for a follow-up email that answers the questions we didn't get to today and that outlines the action steps that resulted from this webinar. I look forward to continuing this work with all of you. Thank you guys so much. Have a lovely rest of your day, and we will be talking with all of you soon.